Good afternoon, and welcome to Voices from the Field. My name is Rebecca Obeng, and I'm a Master of Public Health student in the Department of Health Policy and Management here at the Harvard School of Public Health. As a native of Ghana, I am delighted to introduce Dr. Frank Nyonator, who is currently the Gro Harlem Brundtland Senior Leadership Fellow in the Division of Policy Translation and Leadership Development here at the Harvard School of Public Health. He previously served as Vice Chair for the UNICEF UNDP World Bank and WHO Special Program for Research and Training in Tropical Diseases Joint Coordinating Board. He is currently the Acting Dean of the School of Public Health at the University of Allied and Health Sciences at Ho, Ghana. He currently also sits on the JVI Alliance Independent Review Committee as a health systems expert and is a founding member of the Health Systems Action Network. Throughout his career, Dr. Nyonator has made significant contributions that have helped shape health systems and health policy in Africa. Of note, his dedication to improving health systems and health policy has led to numerous publications and awards, including the Excellence in Partnership and Excellence in Innovation Awards in Ghana. He received his medical degree from the University of Ghana, Legon, and a Master of Public Health from the Leeds University in the United Kingdom, as well as certifications in financial health care in developing countries and health sector reform in primary health care. Before turning the session over to Dr. David Williams, please join me in welcoming Dr. Frank Nyonator to Voices from the Field and the Harvard School of Public Health as he discusses today's topic, championing leadership in pursuit of universal health coverage. Thank you.
Thank you so very much for our wonderful introduction to our guest today, Dr. Frank Nyonator. I think we'll keep things informal and I'll just call him Frank. We really appreciate the leadership that he has demonstrated in developing a program that provided universal access and improved access to primary care in Ghana. And we want to take a good, careful look at that, and there's so many lessons that we can learn today from the outstanding work he's done. To begin, though, I want us to start with a video clip that will tell us a little bit about the program and some of the recognition that it has received.
The Ghana Health Service and the Ministry of Water Resources, Works and Housing have won this year's President's Excellence Award for the public service. The award scheme is part of efforts to reform the public sector and to promote standards of excellence, improve management practices, and enhance services. 10 public institutions took part in the scheme.
The Ministry of Public Sector Reform is mandated to improve Ghana's public service and to inspire best management practices with the overall goal of providing high-quality services. The President's Excellence Award Scheme for Public Service was instituted in March of this year. There were 12 entries from 10 institutions. The Policy Planning, Monitoring and Evaluation PPME unit of the Ghana Health Service took the second place in this category. Their work is the provision of health services at the doorsteps of rural communities. The first place in the second category of partnership innovation between government, private sector, and civil society again went to PPME unit of the Ghana Health Service. The award winners will have the opportunity to meet with the President later in the year. They will be presented with their awards during the celebration of the Civil Service Week next year. Cynthia Pra, GTV News, reporting.
That's wonderful, Frank. You are an award-winning, not many public health individuals receive awards for the innovative work they've done. But I want us to set a context to appreciate both what you did and its significance. Can you begin by giving us some sense of the challenges of access to healthcare services in Ghana, especially for persons residing in rural communities?
Thank you, David, and thank you, Rebecca, for that introduction. I didn't know that he knew me that well. But yes, David, this clip actually brings back memories. It was a long journey from about 2006 to the time that this clip was taken. And for me, the challenge is that most people in Ghana live in rural areas, and we don't have facilities. We don't have facilities to every village. At best, you get one health center to about 30,000 population. And that is huge because people do not get access. They don't even get transport to the places where the facilities are. And so it kind of, people just die out there. The mothers die, children die. Indeed, there is about 5 times the risk of that dying when you live in a rural community where there's no facility.
So you're saying that there's a problem of access, and
Yeah.
you said there's one health clinic, maybe to 13,000 people. And what's the staffing at a typical health clinic?
Well, basically, you have a medical assistant and a few nurses, about 3-4 nurses, and that's it. That's it. And they are catering for that number of people, the 30,000 people.
Okay, so this is the problem, this problem of lack of access to healthcare of rural populations that you made a bold effort to solve. And I want to set it into context again, larger context. There were multiple primary care initiatives in Ghana in the 1970s and the 1980s. What was different about this new initiative that you developed?
Well, clearly, the challenge was more of people having access to health services. And what we had done before was train volunteers to provide services. And but these volunteers were not providing that expert service. So clearly, the people were not getting the service that they needed. And so what we thought we should be doing is send the experts within the context of the Ministry of Health to the houses to make sure that we provide them with the expert services. And the theme is to not let the patients come to us. We go to the patients within the context of our service provision.
So I just want to make sure I'm understanding what you're saying. You're saying the old model is the residents need to come to the experts. And that's the typical model of healthcare access. You go to where the health provider is. And you're saying you developed a new model where the experts went to the people. What does that really mean in practice? The nurses making home visits? What does it mean?
Well, based on evidence that we had developed from Navrongo Research Center, we thought it's very useful and prudent to set a nurse, a practicing nurse, into the community, settle the nurse into the community, and provide her with tools, including motorbikes, to move from house to house on a regular basis. And that is a difference in the module that we are practicing. The old module is we just train community members, and then these nurses go on outreach and give them instructions. But here, the change is to make sure that the nurse stay in the community and wake up and move from house to house to provide the services.
So it's placing nurses in the community and having the nurses reach out to people in their homes with need. You said that this program was evidence-based, and could you tell me a little bit more about the kind of evidence we had that this program would work from research in Ghana?
Basically, when we started our health sector reforms in the 1990s, we were looking for ways of sending services because we realized that volunteer services were not really adequate. And so it was at that time that we recognized that Navrongo Research Center was investigating how to provide community-based services as well as increasing family planning. And so we, 2 years into that research, we went to visit them, and we saw that, well, what they were doing, placing community health nurses in the community and mobilizing the community structures around them, were outperforming the health center that were close by. And total fertility had decreased in 2 years by 1 birth. And the children were coming out alive, were not all dying. So we realized that this was the way to go. And so what I did at the time was, as a regional director, I came back to my region and mobilized my district directors, 12 of them, and bussed them into Navrongo to go and see what was happening there. The interesting thing is that out of the 12 district directors that went there, only one showed interest. And he came and said, well, sir, I want to start this process. And I said, go ahead. And providing encouragement for him to start the process of translating what the research area was doing into real clinical practice.
So this is really interesting, because you're saying that there was good and there was an experiment going on in Ghana that tested the impact of this community nurse outreach compared to other modalities of delivering care, the traditional clinic or just community mobilization alone, and that you found, the research showed, that this community nurse outreach was superior both in terms of increasing access to care, but also in terms of improving the health of the community.
Exactly. Clearly, what we really saw was that with the combination of the community health officer in the community, the community structures like the community elders and all the service providers coming together and putting together their resources was a powerful tool in getting services to the community members.
So this is bringing the entire community to work together
right.
on the topic of health. Now, there's a leadership moment here that we want to really understand better, because you were a regional director at the time, and Ghana had the entire country divided into 10 regions, and you were a regional director with 12 district directors working under you, and you said you brought them to see the program, but only one bought the idea that this was viable. So there's scientific evidence that it's working, and the supervisor invites them to look at an innovative program, but how discouraging must it be that only one wanted to move forward? And what are some of the barriers that exist that would lead people to not buy into good quality evidence?
Thanks, David. In fact, even before I answer that question, clearly, when we visited Navrongo, we were 10 regional directors that went to Navrongo. And out of the 10 regional directors, I was the only person that took it up. I said, well, this is something that I want us to use to reach the unreached people in the communities. Basically, due to the fact that I had experienced an earlier moments of service delivery that was not adequate to people in the communities.
Could you tell us more about that? When you said you had experienced earlier moments, tell us about your early career and some of the lessons that you learned that really shaped your openness to this approach.
After I graduated from Kolebu, I was posted to a district. In that district, we had a district hospital, and there were only two of us in a 180-bed hospital.
So two physicians, 180-bed facility.
And then catering for about 200,000 population.
Wow.
And so you get most of the time either one person is either away, so that one person only takes care of the place. And the typical day is that you might have about 5, 6 cesarean sessions lined up, because people are coming from remote areas where there is no services. And because there is no services, they delay in coming to the hospital, and especially a pregnant woman. And you end up doing 3, 4, 5, 6 cesarean sessions. And so I realized that, well, this is something that we need to overcome. Instead of the people coming, why don't we send services to them, at least provide information to them when they need special care, they can move. So that sort of shaped my life as a physician, to say that, well, I'm sitting here in a hospital trying to save lives. I might not be saving all the lives. There are some people out there that might not be reaching us. So why don't we develop a system which will take services to them and then save at least more of the people who will get sick. And so when we found out in Navrongo that this kind of model is actually the model that sends services to the people. I said, voila, this is what I want. And that was my aha moment. And I said, well, I will take it up as a regional director. So I came back, and all the other regional
And you're going to
directors,
tell us about the skepticism, because I'm really trying to understand how all of the regional directors in the country have seen it. You're the only one that decides to go with it. You show it to your district directors, and only one of 12 decides to go. What were the sources of this skepticism?
well, I won't talk about the regional director's skepticism, but then I'll talk about the district director because I had control over them. And I said, 12 district directors, and only one took it up. So the question was, what exactly was the issue? I could see that, well, most of us, as physicians in third world countries, had that mental model of delivering services only in facilities.
Okay.
People do not perceive that we can go out and provide services. And so most of the district directors at that time, out of the 12, most of them were like, well, yes, we have seen what is happening in Navrongo, but then this is not what we want to do. Our training is more of improving the facility-based services. I wasn't discouraged. Some of them, well, they were always looking at resources which could have been tapped from their own coffers. But then what I tried to do was that the person who said, I want to try, encourage him, and then send the same colleagues who went to Navrongo with him back to him to study what he was doing, so that at least they could learn as peers from what their colleague is doing in putting services to the doorsteps of other people.
So that in public health, there are many times when we have elegant research findings of things that would work, and oftentimes there are barriers to actually implement them on the ground. And you're saying you encountered that in Ghana, but you did not give up. You caught the vision, and you inspired those who were willing to become leaders, and encourage the others to continue. And I note that although you were their boss, you didn't require them to do that.
Well, what I learned is that giving official instruction doesn't work. What really works is trying to get people on board, people to understand that this works. So after Navrongo, when they didn't take it up, I wasn't discouraged. When their colleague took it up and started something, I thought they would learn from their colleague. And so I persisted and was very pessimistic that, yes, this was going to work. And yes, of course, a few of them also took it up, but not at the same scale as their colleague took it up.
We've talked about the district directors, the regional directors. I want us to talk a little bit about the nurses, because the nurses are the ones who are on the ground being asked to practice in a completely different way than they have practiced before. Did you encounter any challenges with the nurses?
Yes, of course. Initially, again, it's a new concept within the service delivery system. And so the whole issue about the fear of unknown, they were not used to that, that they will be relocated from the health center to the communities. And there were issues about their concerns about security, how they will be able to, in fact, link up with their families wherever they are, and also provide the services. So what we did was that the instruction was not to post people to the community. Have a dialogue with both the community and the nurses, and then come to a consensus that, look, they will want to go there, and then give them a promise that you are not being banished into the community. After a certain number of years, you will come back, and then we guarantee you that your salary and your incentives will be paid. And so after this kind of discussions and assurances, Yes, some accepted to go into the communities. But the essential thing is that we also have the communities accept them. So you do community debate to have a discussion with the chiefs and the elders that we are bringing you these services. This is what it entails. This is the support that we need the community to provide these people. And some communities were very fantastic in providing some kind of the necessary support and also enticing the nurses to stay.
Give us a tangible example, just one example of what a community did to show the nurse they appreciated what she was going to do for their community.
There are various innovative ways that the communities actually entice the nurses to stay. I remember one community on every Sunday when they go to church, they put 2 bowls down there for collection, Sunday collections. Mm-hmm. One bowl is for the community health nurse, right, and the other bowl is for the church. And so that, when they collect it, they give her her portion. And that means that she will not touch her salary. But then that shows a sign of respect that we respect you for staying in this community. Most typical communities actually do farming for the nurses so that the products on that farm are for them.
So you mean they would dedicate some of their produce to benefit the nurse?
No, they will actually demarcate the land and farm for her.
That piece of land just for the nurse?
Yes, for the nurse. Okay. So that, yes, of course, then whatever is coming out of there, she doesn't have to go and
do the farming herself.
But others in the communities are mobilized to do it, and then it's her. When the foodstuff is ready, she go and pluck them. They give animals occasionally. Anytime the nurse does something very nice to them, you see a family, they don't have physical cash to give. They have the animals to give. So they give either chicken, hen, goats. And so those are really moments where these community health nurses enjoy. And there have been cases where after 3 years and you want to move them out, they say, no, we are not moving out.
The nurses wanted to stay.
Yes. And they stay and are willing to mentor other newer community health nurses as to this kind of way of delivering services. And they had become the most dedicated workers in the service of Ghana.
Wonderful. So this is really remarkable because we are looking at major changing of the healthcare system, but really empowering communities to take responsibility for their health and to, in fact, support and collaborate with the healthcare system that is now delivering care in a new and innovative way. I want you to talk a little bit about the national visibility and your work in terms of bringing national visibility to this work, that this eventually became the national program of Ghana. Tell us about how you moved from 10 most district directors not interested to it being spread throughout the multiple communities and this becoming a national program.
Yeah, well, within the context of putting it all together, the Ministry of Health was also going through its sector reforms. And so we had created a new structure called the Ghana Health Service. And so we had to operationalize it. And so I had to move from the region to become the first director of policy planning, monitoring, and evaluation. That means that I now have access to even the regional directors again from another level. And so what I did was, because I had developed this passion for this program, and I want to see it work. We had a regular meeting with the regional directors, trying to bring champions from the districts that were operating to come and make presentations for these regional directors to see how we are progressing with this and what the benefits of moving services into the communities were. that had some profound effect. But the key thing was that I had to also sit down to develop a policy guideline from my division to guide all these issues. So you had to bring the regional directors in to also get their perspectives about this policy guideline. That video clip that you saw was a result of one of the processes of getting the information across. So we put together a report to the Ministry of Health Sector Reforms, and voila, it was an award winner, and that changed the perspective of both the regional directors, most of them who were skeptical, and then most of the national directors, as well as our partners, the European partners. So from that moment onwards, CHIPS became one of the strategies that is part and parcel of the health sector reform process.
Wonderful. So I think what I'm learning from you is that really important keys were exposing the regional directors to success stories, the communities where this program was working, that really had a powerful impact, and then developing a national written plan for it. What lessons, we want to get questions from the audience, want to get the audience engaged in a minute, but my last question before we do that, what lessons can we all learn about producing system change? Because that's what you did. You produced systems change in Ghana. What lessons can we learn about producing systems change?
Well, that's kind of an interesting question and a way to put it. In the first place, I didn't realize I was doing a systems change. All that I was following was the earlier feeling that I had as a medical officer, seeing all these pregnant women come in at a late stage, and we have to repair their ruptured uterus. And I thought the passion is to send services to them rather than waiting for them to come. And so and this I thought fitted into the whole concept of primary health care. And the research even provided evidence to support it. So I thought that the passion was that this is what we should be doing. And nobody else was going to convince me else to do something else. So indeed, it is that passion for what I believe in that drove me to the levels that at one point in time at headquarters, the national headquarters, most people were skeptical about CHIPS.
And CHIPS is the name of that
innovative
program.
Of the program. And I became the sole champion at headquarters. And I was given a nickname, Mr. Chips.
Okay.
And currently now, I'm now grandfather of Chips.
Okay.
But it's like you needed somebody with the passion and the belief that this will work to survive in that environment. And indeed, I had to, every forum that we appear in, every program that I appear in, CHIPS was on the agenda. And I made sure that everybody got fed up with understanding that CHIPS is on the agenda. So at one point in time, our first Director General of the Ghana Health Service asked Frank, what is it in CHIPS that you are so passionate about, that nothing else matters but CHIPS? And there was an evaluation even done by the Public School of Public Health. And the report was that the Director of Policy Planning, Monitoring, and Evaluation of the Ghana Health Service has taken CHIPS as his personal property. That is to the level at which the passion has driven me to the point that everybody now says that this man is only talking about CHIPS.
So you are saying that leadership matters, and every good cause needs a champion, and a champion who is really committed and resolute to it. We want to get the audience involved and engaged. Are there questions from the audience for Frank? Yes, right up front. Do we have a microphone? Yes. Stan, give your name and
Hi, thank you very much, Professor, for being here. My name is Leo. I'm an MPH student here in healthcare policy and management. And we were talking about producing systems change. And I was wondering, you were talking about CHIPS and that interesting program. And my first question would be if you can brief us and the rest of the audience on what exactly was CHIP consisting on. And the second question is, here in the School of Public Health, one of the things that we struggle the most with is the objective of achieving universal health coverage. And I would like to know your personal opinion about what was the impact on CHIPS on achieving universal health coverage in Ghana.
Thank you very much, Leo. The word CHIPS is basically community-based health planning and services. It's community-based health planning and services, meaning that we have a service provider who is a former employee of the Ministry of Health as a nurse, as a frontline officer, being located into a community which is demarcated for her services, and her duty is to move from house to house, providing certain basic services to every household, from the mother to the child to the father. All right. So within a defined area, the assignment for this frontline health worker is to deliver these basic services. But she was also supervised from the next level, that's the sub-district level, by her supervisors, and then also within the district. So it's a kind of a system arrangement within a district, and it becomes the lowest unit of service provision in the Ghana Health Service. When I look at the current controversies going on in universal health coverage, kind of don't seem to understand what is a controversy. We are saying that we want to send services to those who need it most in an efficient and effective manner, but also ensure that they don't suffer any financial hardship. Simple. So sending services through these cadres of staff is something that countries need to be working on, and providing that support where financially the households are not encumbered. So there are various mechanisms to do that one. You can either do it as a free service, or you do it through national insurance. So for me, I don't see how this program cannot lead to effective universal health coverage in the country.
And in the case of Ghana, the program not only improved access to care, but it also improved health outcomes, right?
Exactly.
Tell us a little bit about that. And then we want another question.
Well, Ghana's indices are improving as compared to the other countries around it, and we have moved from a maternal mortality ratio of 750 to about 350 now. Life expectancy in Ghana had moved from the time that we started this program in the 1990s, about 48 years, to right now we are talking about averagely 64 years within 2 or 3 decades.
Wow.
And consistently, total fertility rate has declined from 5.2 to basically 3.8 and 4. So the indices are really moving within the context of fact that we can also attribute that it is because we are sending services to the population.
Other questions from the floor? Just raise your hand. Could someone get microphones to them? I see. Yes, thank you.
Hi, my name is Asari Christian. I'm also from Ghana, so thank you for being here.
Thank you.
I think this is a great model. This is the first time I'm hearing of this. My question is, what mechanism were put in place to integrate CHIPS with advanced medical care, things that were beyond the scope of nurse practitioners or nurses, to make sure that people that have complicated issues are taken care of?
Okay. Thank you very much. I wish you have attended my session, my class session, and this was one of the one of the areas that we had deliberated on very well. How does it link with the rest of the system, and what's this referral and support and supervision systems that all we have taught it out very clearly. The district health systems is the basic unit for the ministry. And within the context of the district health system, at the apex is the district health management teams and the district hospital, providing the basic hospital care. Below that, we have the health center, where the medical assistants and the public health nurses sit. Below that is the CHIP zones, as we term it. And so clearly, it provides a clear line of reporting and referral system for us. The nurses that are deployed in the community are given very strict instructions and rules and regulations as to what they should do if a case is beyond them. What is the level, when do they refer and when do they not refer? These are all guidelines that have been produced for them, and also supported by support and supervisory visits from the health center. The medical assistant, together with the public health nurse, do regular visits where the system is working very well. We all know that sometimes, because of resources, support and supervision becomes another problem altogether. But where the system is working, that chain of command in service provision is clearly laid out. And the idea is that the nurse at the community level will provide both preventive services and clinical services. And so what they do is that whilst they go from house to house, they have a small place where they consult. But the policy is also that we should not turn those small places where they are working into small health centers or hospitals in the communities. That would defeat the purpose of the concept of CHIPS. So there are kind of systems that are in place to bridge the gap between clinical service and preventive services.
Another question at the back.
My name is Raphael. I'm in a doctoral program at the EH department. I'm from Ghana as well.
Thank you.
So my question is related to health outcome, how to capture and show that we are actually making progress as a nation. And you talked about how life expectancy has increased, maternal health and maternal death decrease. And I'm interested in looking at, even though countrywide we have good indication compared to other countries in the sub-region, how can we tell that if you move from north to south, we have a big divide, whether at the local level, across districts, across localities, across towns, as you move from north to south, whether each of those districts are making equal progress towards achieving some of the targets, for example, MGD4 or MGD5. And the key question is, we don't have data to be able to analyze at those levels. So as we look beyond what we are doing now in terms of coverage, what are the structures put in place to be able to capture data so that we can analyze and do risk factor analysis for the country to say that, yes, indeed, we are making progress, not as a country as a whole, but equally from the grassroots to the top. Because I'm sure that most of our indices are driven by the southern part of the country. Thank you.
Thank you very much. And again, this is a chance for you to have come to the session. If we had had this discussion before the sessions that I would have encouraged you to come, I'm sure those who are in the session will have told you about there are various initiatives that are going on. One of them is the reform of the health information system. The health information system currently in Ghana, where we move from what we call District Health Management Information System 1 to District Health Management Information System 2, which is web-based. It has increased the way that we collect data and also the focus on transactional data. So let me give you a typical example. Each chip zone, that CHO has ways of collecting transactional data that are collated on regular basis. And this then feed into the sub-district data. And there's a team that is at the sub-district that also look at the data on regular basis, collect it before it goes to the district level. And they are encouraged to use this data to make informed decisions. All right? And that is a huge national program that is going on. And from the district level to the regional level to the national level. That reform, information reform system that we've put in place had actually assisted us to start disaggregating data, not only district by district, but even chip zone by chip zone, to compare what are the indices in this community as compared to this other community. And this data is not physically transmitted, but it is web-based. And so managers at the national level, at the regional level, at the district level, can access their own data and make informed decisions, disaggregate it into even various communities to ensure that, well, see if who is performing and who is not performing well, and are we achieving our targets or not. So there's that huge reform of the information system that is supporting the service delivery reforms.
It's wonderful. There's another question up at the front. Yes.
Hi, my name is Paul Ashigbi. I'm sneaking in from Boston University. My sister Vero, who worked with you on this project, yes, told me a lot, so I'm quite familiar with some of the stories that you have shared. My question is, what next? In other words, the vision that you had, has everything been achieved, or there's still something that you want CHIPS to do?
All right, thank you very much, and I'm sure your sister Vero will have told you a whole lot of other stories anyway. Now, clearly within the context of the sessions that I'm running, these are innovations that we put in place in Ghana. One thing that we need to do as a country is to see how all these innovations tie up together. We have National Health Insurance Scheme. We have the CHIPS. We have the information system. We have mobile technology initiatives that are coming. All these are directed towards improving the outcome at the household level. What we need to do from the leadership of the Ghana Health Service and the ministry is to ensure that all these components come together. So they need to talk to each other. What I find a bit frustrating now is the fact that National Health Insurance doesn't talk to the health sector, the Ghana Health Service. So we have a problem with deciding which package of services are covered here and there. And I think that is a key challenge that we need to look at the national level as well as the regional level. We're also looking at government's move now towards total devolution, decentralization, where it is projected that the district systems will move from the Ministry of Health into the local government. Yeah, that is a huge challenge that we need to start preparing ourselves to say, what is the ramification for service provision? So there are quite a few challenges, and I'm hoping that we can overcome this, develop mechanisms that all these systems talk to themselves.
More questions from the audience? Yes, I see a hand all the way at the back and then one at the front.
My name is Abimbola Chrysolai. I'm from Nigeria. I'm the MPH program.
Looking back at what you said, I remember a year after my internship, I was working in an environment where I was the only doctor of in charge of probably 8,000 people, and there was a challenge of delivering service because of cultural and religious differences. So I want to ask, at any point in time, is there any concern for cultural religious conflict that could have a negative effect on the success of the program that you championed?
Well, that's interesting. Ghana and Nigeria sort of cousins, but then poles apart when it comes to cultural and religious issues. Indeed, the frontline officers that we have, majority of them are women. And they are accepted in all households. When we are tempted to get male involved in there, we had a few pockets of areas in Ghana that males are not allowed to examine women when they are going to deliver. Okay, so we had to now step back and say, well, okay, in these areas there will be an issue, so we will not get male into that system, but we will do it in these other areas. But we are also conducting operational research to see, are male midwives accepted across countries? If they are not, what are the parameters that we can use, and what is it that, where can we use them? Can we use them in the southern sector, and whilst we concentrate on using women in the northern sector? So these are all research questions that are coming up as we move towards sending services to the people and the category of people that we send the service to. Ghana is predominantly a Christian country. I think we are about, Christianity is about 60%, and Muslim is about 30 or so percent. But we all live in harmony. We haven't had any cultural or religious clashes yet. Well, a few skirmishes maybe, but not at the scale of this. So I won't say that we'll face problems in service provision by that way of cultural or religion playing a part.
Another question in front?
Yes, thank you. My name is Rebecca Obeng again. I'm the MPA student in the Health Policy Management Program. My question is, it seems like the National Health Care Program made it a fertile ground for the program to sort of move forward and become successful, because you're going in, people don't have to pay necessarily to get those services. My question is, do you think it would have succeeded if the country didn't have a universal health care system or health insurance program? And if it didn't have it at that time, what could you have done to have made the program still succeed in light of people not having universal insurance to cover their services?
Rebecca, are you asking us to consider a situation where national health insurance is non-existent?
Right. How do you go
how,
about
how would we have gotten there? Well, that you just simply have to look back to the immediate period post-independence, when we didn't have insurance, and all services were funded by government. And as we move along, government contribution towards health sector drastically reduced, dwindled, and there were no monies for services to be provided at the facilities. And it was at that time that the World Bank advised us that we should try and put user fees in place and recover at least 15%. And that was not even successful. So we moved on to what we call...
That was 15%, not 50.
15.
Yeah, just making sure I heard right.
15%.
And that was not successful.
That is not successful. Then we move on to recover full cost of drugs. And that, you might have heard, was called the cash and carry system. And I can assure you, if we're old enough, you have realized that there were so many horror stories about that cash and carry system, that had moved us into taking the decision that we want to move into a health insurance scheme. So we've had enough history and evidence from a period there was nothing like the insurance into a period that it is. So what I'm trying to say that yes, there are, if government is committed to giving all the resources, then of course health insurance might not be necessary. But government cannot do it all. And so we need to find new ways of investing into health so that we can send services to the people. So remove insurance, we might not attain our universal health coverage.
We probably have time for one last burning question and one brief answer because we're almost out of time. Yes, right ahead at the front.
Miranda Daniloff-Mancusi from the Harvard School of Public Health here. You're here at a very interesting time in U.S. politics. I am wondering what your impressions are of how the ACA is being rolled out, and perhaps what advice you might have for President Obama.
Short answer.
Will it be politically appropriate for me to be brutally frank?
Yes, you can be frank.
No, well, again, for me, I think reading all the press reports and things like that, I think the U.S. tried to achieve perfection right from the start. What we did in Ghana was that we don't have any blueprint, but then we forge ahead and put a system in place, and then learn from doing, and then move on, because there was the real need for us to put that system in place, whether it's we've gotten it right or not. But currently, we are now talking about getting 34% of the population on that system, and then we are learning technically as to how to move beyond the 34%. So, start something.
Right, so make a first effort. Frank, it's been wonderful to have you as our guest today on Voices from the Field. Do you have one final closing comment for our audience?
Well, I will tell my younger colleagues that, look, whatever you do as a leader, you need passion to push you. But once you assume leadership position, you cannot really deliver that leadership position by just giving administrative instructions. You need to build consensus, you need to build understanding, and then develop people who will rather showcase what you are thinking, champions within the system. And then rather than you going to talk to the others, you send them to those champions for them to provide them with the necessary understanding of what needs to be done. And also at the national level, I have always encouraged regular forum for dissemination.
Frank, I have learned a lot within the last hour. Thank you so much. A very simple idea. Don't wait for people to come to you for healthcare. Take healthcare to where the people are. What a simple idea, and why isn't it elevated to a much higher level, not only in the country of Ghana, but even in places like the United States. Thank you so much. We've learned a lot from you today, and this has been a wonderful session on Voices from the Field. Thank you.
Thank you very much.